All right, thanks, Brendan. Can everyone hear me okay? Thank you for that kind introduction and for the opportunity to come and present to you today. The weather is noticeably less good than Hawaii, but it's been lovely to be in California again and be in the Bay Area. So this is a topic that is the focus of my research program, but also something I feel passionately about that we as a specialty in anesthesiology need to focus more on. And so I hope that you'll come away from this with at least some pearls around clinical practice and areas that we need to focus research on in the future. I just have a few disclosures. I have research support from these two nonprofits, and then I receive financial compensation from the CJA for my work and up to date. So our objectives for today are, we're going to do three major topics. So we're going to compare the incidence and risk factors for perioperative stroke after non-cardiac surgery. So the focus of my talk is non-cardiac surgery. Cardiac surgery would be a whole other talk, although we can touch upon it. We're going to look at some preventative optimization and intraoperative strategies to prevent perioperative stroke, as well as the recent guidelines that are published. There are 2 published guidelines, and I'll refer you to those at the end. And then discuss some of the postoperative diagnosis and treatment and outcomes of perioperative stroke. When it does happen, what can we do about it? So the first thing to understand is, what is the definition of a perioperative stroke versus a typical or a non-perioperative stroke? And really, it's any brain infarction of ischemic or hemorrhagic etiology that happens within 30 days of surgery. And I recognize this is a very arbitrary cutoff. Like many perioperative outcomes, we cut off at 30 days, but there does have to be a distinction between perioperative stroke and non-perioperative stroke. However, I would say between 29 and 31 days, it's probably still a consistent, there's a spectrum of when that happens and how it relates to surgery. But this is how all the guidelines define this. And why do people get perioperative stroke? So the vast majority of strokes after surgery are ischemic in origin, which makes sense because most strokes are ischemic in origin, but there is a small subset of hemorrhagic strokes. And after specific types of surgery, that would be more common. For example, after carotid surgery, carotid endarterectomy, you might get a hyperperfusion hemorrhage. But there, in terms of the ischemic stroke etiologies, it's a combination of embolic strokes and thrombotic strokes. In cardiac surgery, it's more embolic than thrombotic. And there is a subset of hypoperfusion strokes, which is really when the blood pressure is low, but that is a small subset and not a driving cause of perioperative stroke, despite what some of our colleagues in other specialties think, because I think we often get blamed for a stroke. And certainly we make a stroke worse, but hypoperfusion is not a dominant reason why people get perioperative stroke. And if you look at the incidence, so how common is this? So most people will say it's very uncommon because typically we haven't heard of our patients having a lot of strokes. If you look at all comers to surgery, and George Mashur in Michigan did a very seminal analysis in the NISQIP database, which is so large that it allowed us to have a fairly accurate overall analysis of the incidence, was only 0.1%, but that included everybody from every type of surgery, including some very minor surgeries in very healthy people. But when you start to enrich your population to more risk factors, such as the POISE trial, which was a randomized trial of patients with higher cardiovascular risk, you see, and that was a prospective trial, so it's going to be quite accurate in terms of its incidence. It was 0.7%. If you look at people who have a history of ischemic stroke, this is just one study, but it was almost 3%. So it jumps quite a bit. And then covert stroke, which we're only just beginning to understand. We know from the Neurovision trial done recently that it's about 7% of patients. So you can see that although it's rare overall, there's definitely, it's much more common in certain populations and certainly approaching the incidence of myocardial infarction. So I did this rough back of the envelope calculation, but if you perform about 500 anesthetics, which I think is, I mean, we all have different practices, but that's not totally unreasonable for most of us. And your overall stroke rate is 0.2%, which is also a fairly low rate. So some of you are probably doing anesthesia on patients with higher risk factors. The average anesthesiologist will have a patient with a perioperative stroke once per year. But I would imagine, like many of us, we say, well, I have barely heard of my patients having them. And it's likely because we don't know about it all the time because it happens in the days after surgery, but it does happen. The other concerning thing, this analysis done about 6 years ago, just looked at trends over time in the incidence of these complications. And what's really interesting about stroke is that if you look at major adverse cardiovascular events, death, and MI, they're all stable or declining, as you can see on the bottom. But unfortunately, perioperative stroke is actually going up over time. And we don't know why this is. This analysis didn't explain that, but you do wonder whether there's been a lot more focus on cardiovascular complications. And I know in our hospital, we do a lot of troponin screening after surgery. So we're quite vigilant about that. But perhaps we're missing the people who have stroke, and we really lack ways to intervene that make people do better. So we're just going to do questions. You can answer it for yourself. You don't have to put your hand up. But which of the following are risk factors for perioperative stroke after non-cardiac surgery? So it's chronic renal failure, atrial fibrillation, being older, or all of the above. And if you're a good test taker, which I assume most of you are, it's obviously all of the above. Those are all risk factors for having a perioperative stroke. And again, this is Dr. Mashur's analysis from NISQIP, which again, because it's such a rare complication, this analysis actually provided us with the first robust analysis of risk factors. So some of them make sense. Being older, having a previous MI, so having cardiovascular risk factors, having renal failure is definitely a risk factor. And history of stroke or TIA, as I'll show you later, is a major risk factor. BMI in this analysis was protective. I think it's likely a confounding variable. There's probably something else. I don't necessarily think having a higher BMI protects you against stroke, but there's probably something in there that's confounding it. The NISQIP database does not include all variables. So I like to bring in these other studies just to reinforce that atrial fibrillation and valvular disease are also risk factors. They're just not in the NISQIP database. But this analysis confirmed a lot of other of those risk factors as well. So when you look at risk, if you look at a low risk patient, so that's less than, this was in that NISQIP analysis. If you have 2 or less risk factors, your risk is very low, so 0.1%. So this is a very low chance of happening. But once you start to get 3, 4, and then 5 risk factors, your risk goes up quite a bit. So if we were to tell someone you have a 2% risk of having a major stroke after surgery, I think most patients would consider that fairly important information and meaningful, because these strokes, as I'll show you, have poor outcomes after the surgery. We can also look at the type of procedure, and you can see there is variable rates. Vascular surgery is obviously always highlighted as a very high risk population, but so is in this case small bowel resection or major colectomy. And you can see that the risk goes up always with age. So when you're looking at someone who's over 65 having an amputation, that risk is at 1%, which is the overall risk actually quoted for cardiac surgery. I'm going to show you a few risk factors that are more investigational, but are interesting. I think this one's very interesting because it looked at the relationship between patients who had a history of migraine and having a perioperative stroke. And you can see that patients with migraine had they did a multiple adjustment there of over 100,000 patients. And they found that any history of migraine gave you an increased risk of having a perioperative stroke, but specifically migraine with aura was the highest risk. And we don't know why this is exactly, but it does indicate there could be some kind of cerebrovascular modulation issue with those patients. We don't know what to do with this. So I don't tell anybody, I don't tell my patients this because I don't know there's nothing we can do to mitigate it necessarily, but I think it's an interesting piece of information about how we might go ahead with treating and understanding what happens with perioperative stroke. Another interesting one is patients with patent foramen ovale. So patients, we know that they are at high risk of stroke in general without surgery, but there's been a few analyses looking at whether it relates to perioperative stroke. And this was the largest one that looked again at 150,000 people and found an adjusted odds ratio of almost 3% for patients who had a history of PFO. And then there was a subsequent recent systematic review that assimilated all of the evidence on this and identified that PFOs are certainly a risk factor for having a perioperative stroke, but they said it was low quality evidence. And by that, it's mostly retrospective, almost all retrospective database analyses. Also, for those who are cardiac inclined, when they looked at TE diagnosed PFO, that also changed lowered the risk and mitigated it. So it's possible that we're not understanding the population that's getting diagnosed with PFO in this administrative database. And so we need to understand this better. And we certainly don't know if treating the PFO is actually going to reduce the risk. But again, it's one of these interesting observations that does give a mechanism for how some patients get a perioperative stroke. So do people talk to their patients about risk counseling, about stroke? Because my experience was that people don't talk to their patients about stroke the same way we talk about cardiovascular complications, at least in Canada. So we surveyed patients to see if if they knew about their risk based on their own risk factors. And we also asked whether anyone had had a discussion with them about stroke. And what we found is that most patients had not had a risk discussion. Even the highest risk patients, only 40% had had a risk discussion with their physician, which isn't very good considering we're talking like into the 3% range likely for most of those patients. And patients who were high risk or lower did not understand their risk stratification innately. So people assumed that they were lower risk than they were, and they also didn't talk to people about it. So in this sense, there's a lot of work to be done, I think, around risk counseling. We then surveyed Canadian anesthesiologists to see if they did talk to their patients. This was done before that previous study. And although that most people agreed it was important, only 46% admitted to routinely discussing it. And I suspect that's higher than reality because people tend to not want to admit to those things. And so that just shows again that we have a lot of work to do in terms of discussing these complications with our patients. So now we're going to move into prevention. So how can we, if we identify someone as being high risk, how can we actually mitigate that risk? So this has been a very key question that's come up in recent years. How long should we wait to do a surgery, especially in a very elective surgery, after someone has had an ischemic stroke? Should we not delay? Should we just go ahead, no issue? Should we delay for at least 3 months, or should we delay for 6 to 9 months? So if you'd asked me this like 2 years ago or even a year ago, I would have said 6 to 9 months. But actually we're going to go through, there's another big paper that came out last year that suggests that maybe that's a bit conservative. So this was the original analysis that up to this point, we had actually no information about how long to delay. And I found that we'd go to our neurology colleagues and they would typically say, well, some of them would say a month, some would say 3 months. And it was it was a bit ambiguous and it was all based on estimation and not on data. So this was a very large analysis in Denmark of almost 500,000 people. And they looked at the interval between patients having an ischemic stroke and then having subsequent surgery. And about 1.5% had a history of stroke. And what they, and I'll show you the results in detail in a moment, because I'm going to compare the two for you. The other study that came out just last year was actually in the US on Medicare patients, very similar type of analysis where they looked at the interval and how that related to their subsequent risk of stroke. But obviously and this was almost 6 million patients. This was a slightly different population. This was obviously older patients because it was only Medicare, whereas the Danish study was all comers. And so what you can see, just the way they presented their data, the Danish study, I've had to give you unadjusted percentages, but just to give you a sense of what the overall risks were. So this was the risk of having a subsequent stroke. So if you had no prior stroke, obviously your risk is lower. That is a universal finding, that if you've had a prior stroke, you're definitely at higher risk. And what seems consistent is if you have surgery within 3 months, you have a noticeably higher risk of like very significantly higher risk of having a subsequent stroke. After that, it gets a bit more murky. So the Danish study showed that it didn't stabilize risk until about 6 to 9 months. They found 9 months to be the sort of key plateau time. But the US study actually looked like the risk stabilized after 3 months. So that suggests that maybe the Danish study was that recommendation was perhaps a bit conservative. And then when you look specifically at just elective arthroplasty, so this is just because it's a very elective procedure that we can delay, you can see that when you looked at, this was in the original Danish study, the risk under 3 months was very high in this study. So it's 20% absolute risk and a 27 fold odds ratio of having another stroke. So clearly doing elective surgery within 3 months is likely not a good idea if we can delay it. But when you move out of that, they found that it declined significantly, especially after 9 to 12 months. So this is a graph that I made, so it's not, you don't have to take it verbatim, but it just gives you a sense of what both studies showed. They had quite different incidences of overall and odds ratios of stroke, and they had slightly different populations and also ways of analyzing it. But the recommendation that I would give would be to delay a minimum of 3 months. That's a consistent finding, and possibly up to 9 months if you can, if it's purely elective. And I recognize there's a whole spectrum of how much we can delay surgery. Even a hip replacement for some people, quality of life, they may want to go ahead earlier as long as they understand the risk. So I think between 3 and 9 months, we can have a risk benefit discussion with our patients, but I've actually become less conservative with that recommendation. Initially, we were quite strict that they should wait for 9 months. Now, what about emergency surgery? So we can see that this was a similar group in Denmark, did a different paper, a different analysis, only at looking at emergency surgery. Obviously, we can't delay that 9 months. So they were primarily interested in short, immediate surgery versus a very short delay of 2 weeks. The first thing they found consistent with their other analysis is that the closer to a previous stroke you've had, obviously the higher the risk of dying, having an MI, and having a stroke. So that's just consistent with their previous analysis. And when you get into the details around, this is obviously retrospective, not randomized, but the patients who had immediate surgery certainly didn't have an increased risk compared to those who had surgery within 4 to 14 days. And actually, there may have been a slight increase in the risk of stroke or major adverse cardiac events if you waited the 2 weeks. This is hard to, I wouldn't say it means it's worse to wait 2 weeks, but I would say that the signal here was that there seemed to be no increased risk if you did surgery immediately. And this would, to me, would be the type of patient who had a hip fracture, who had a stroke at the same or very shortly before their fracture. And now should we wait 2 weeks or should we just do their surgery? I would say this supports that you don't need to delay for stroke risk necessarily, but obviously it's patient dependent. So in summary, for timing of surgery, which I think is a key part of stroke management and mitigation of risk, is emergency surgery appears to have similar outcomes, whether you do it right away or with a short delay. And elective surgery seems reasonable that we delay 3 months at a minimum and possibly 9 months if it's purely elective surgery. So I'm going to go through a few other potentially ways that we can avoid risk or increasing people's risk. So this was the original POISE trial, which randomized, this was for prevention of cardiac complications, but they randomized people to receive fairly high dose metoprolol the day of surgery. They started it and then continued it throughout the perioperative period. And what they found is, as you might recall, that metoprolol did reduce the incidence of MI, but it led to an increased risk of stroke, hypotension, and mortality. Now, obviously, the incidence of stroke was still quite low, even though this population was high risk. But they actually found a significant difference in stroke risk with metoprolol. And the metoprolol patients had more hypotension. So again, the study wasn't looking specifically at stroke, but I think we can extrapolate that starting patients on beta blockers immediately before surgery is not good from a stroke perspective, but also likely not good for hypotension and other factors. And one possible explanation, although this is just hypothesis generating this analysis, but it's very interesting if you consider the effect of anemia with the beta blocker. Different beta blockers have different selectivity, and the non-selective ones like metoprolol it's possible that they may impair autoregulation and patients' ability to compensate for anemia. And so what they found in this analysis was if you were on metoprolol, you had almost a synergistically, it exacerbated your risk of having a stroke in the context of anemia. So it's just a thought that that might be one of the mechanisms by which metoprolol increases the risk of stroke. And what about aspirin? So there's been no specific study looking at stroke risk in aspirin, but the this was a follow-up POISE trial, found that which randomized people to placebo or aspirin, did find a very similar risk between those who were on aspirin at the time of their surgery and those who were not. But you can see like a fairly decently wide confidence interval. There were very few strokes in this. I think there were only 3 and 12 in each group. So it's hard to make a conclusion from this, but it didn't suggest that there was a major effect, I would say, between the two. And it will be hard to do a randomized trial that's bigger than this to look at this question with stroke. Now, bridging of anticoagulation. So I mean, the study is a bit old now because people were all on warfarin, and now our patients are generally not on warfarin. But as you might recall from this study, they looked at whether it was beneficial to patients to bridge them on low molecular weight heparin or not, because we used to bridge almost everybody at my institution before this paper came out. And what they found, there was a higher risk of major and minor bleeding with patients who had received the bridging treatment. And actually the risk of stroke was the same, as well as all arterial thromboembolism. So basically there was risk without benefit. So as far as stroke risk, bridging people who are generally not super high risk with their atrial fibrillation, who are on warfarin, is not necessary. Now, if we look at perioperative hypotension, so this is another area that's had a lot of investigation. Does having low blood pressure during the surgery impact your risk of stroke? Because a lot of people would have hypothesized that it would potentially increase your risk of stroke, given that we think there are a small subset of patients who have hypoperfusion strokes. So this was a very large analysis of almost an administrative database, 358,000 patients, low risk of stroke, but 0.4%. And they had very good data on their blood pressure intraoperatively. And they actually they did a very robust analysis looking at different types of hypotension, duration, relative versus absolute, reduction in blood pressure, all the different ways that we might look at blood pressure intraoperatively. And they did a lot of adjustment for major confounders for outcome. And what they found was that there was actually no association. And I think if there was a major relationship between the two, the study probably would have come up with at least something in that analysis. So I think this does contribute, and this finding was robust across multiple subgroups and sensitivity analyses. So I do think that it's difficult to say there's a strong relationship between hypotension intraoperatively and outcomes. Now, there's no randomized trial on blood pressure control and this outcome, but you would expect to see some signal in a retrospective analysis, I think. This was just a systematic review looking at generally at outcomes and hypotension. And these are all different kinds of outcomes. And when you see red, that means that they're associated significantly with where hypotension is associated with this outcome and complication. And what you can see is all of the other ones mostly, so organ injuries, kidney injury, MI, mortality, all have significant associations with these complications, but stroke is all yellow. So across multiple studies, they have failed to show that there is a significant association. So again, I just think this doesn't mean there isn't any, but I think that this doesn't suggest that there's a very clear and strong relationship between the two. This was a very recent study published out of Michigan that looked at specifically on carbon dioxide and tidal CO2, which is a very good question that no one had really looked at in this context, as well as blood pressure. And we'll go through the CO2 in the next slide, but the blood pressure, they did actually find in this analysis, they did a case control study that having a mean arterial blood pressure less than 55 did show an increased risk. So again, the literature is inconsistent. And this analysis maybe was a little more specific because it had a pretty good outcome case control and a lot of patients that they pulled from, over 1 million. When they looked at end-tidal CO2, what they found, interestingly, because you would think, well, if we hyperventilate people inadvertently, maybe that's causing reduced cerebral blood flow and then exacerbating stroke or causing stroke. Conversely, if we hypoventilate patients, we can cause steal and other effects that may be detrimental to the brain. And what they found is actually both having a high CO2 over 45 and less than 30 did associate with an increased risk of having a perioperative stroke in this case control study. They also looked at the interaction between hypotension and CO2, which there's a lot of interest in, because if you're hypotensive and you have hyperventilation, there's a thought that could really detrimentally affect your cerebral blood flow and perfusion. But they did not, in this association, they did not observe any interaction between the two. So this is very interesting. It doesn't tell us what to do with CO2, but I think it does suggest that we should be continuing to investigate the role. Now, what about carotid artery stenosis and stroke? So we know that if you have carotid artery stenosis preoperatively, you have a higher risk of having a stroke after cardiac surgery, but in non-cardiac surgery, that role is less defined. And certainly based on the current guidelines, although there's been no prospective trials, a routine prophylactic carotid endarterectomy is not recommended. So if you detect somebody who has even high-grade stenosis, but has no symptoms, it's the usual indication to do a carotid endarterectomy. So if they've had a stroke, certainly they should go into that pathway. But if it's purely just hearing or bruit, but they're asymptomatic and no stroke symptoms, there's no recommendation to go ahead with prophylactic treatment. Now, what about anesthetic modality? Because I think there is still sometimes a perception that if we do regional anesthesia, we keep them awake, or we avoid a GA, that maybe that's better for patients who are high risk for stroke. Again, we don't have really robust data on this. There's sort of inconsistent associations between different anesthetic modalities. I think those are very confounded by indication, like most of those studies. But what we have these two, we have the hip fracture study, or we have these two NSQIP analyses. So they're high volumes of patients, but they're also less robust to confounding. You can't adjust for everything. And even type of anesthesia is often miscoded, I find, in NSQIP. But in one of them, they found GA was associated with a higher adjusted risk of stroke when they adjusted for all those variables. But as I said, NSQIP doesn't always include all the risk factor variables. And then in the other one, it didn't associate with GA. So I think this shows there's a bit of ambiguity. And then when we look at these two recent hip fracture trials, which are very good trials that randomize people to regional versus general anesthesia for hip fracture, so they're robust, they have good outcome follow-up. Neither of them showed a difference in stroke between the two groups. But there's a very low incidence of stroke in these trials, even though they were in very higher risk patients because they had hip fracture and they were elderly. But in one of the studies, there was only one stroke. So I don't think you can draw a lot of conclusion, but it doesn't suggest that there's a big difference. So now we're going to move into detection. So this is a case report we just published. I think it's a good illustration of, this is at our hospital, of how difficult it can be to diagnose a perioperative stroke compared to in the community. So this was a man who had a radical nephrectomy with an epidural. He was a high-risk patient. He was a smoker, he had renal dysfunction, he was frail, and he had cancer. So he was put in our high acuity unit for monitoring. On the first day he came out late in the evening. He noted motor weakness of his hand. This is a photo from the internet, but it did look a bit like this, sort of that claw hand. But he didn't report it to the nurse and nobody noticed it. Nobody clinically noticed it. So the next day, it's now noted by staff, but it's by the medical staff as well as the nursing staff, and he's bringing it up. most people, the clinical team thought it was an ulnar neuropathy because it seemed consistent with the motor deficit. The patient otherwise was doing well. So ambulating with the epidural, alert oriented, had seemingly normal motor function elsewhere. So the next day, the patient did not improve. And so the neurology service was consulted and a CT head was performed. And then when neurology examined the patient, they noted a mild right-sided weakness, which I think it was very subtle. And the CT showed a cortical hand stroke, which is a very specific stroke syndrome, which is specific to only affecting the hand, which I actually was not aware of before this. And he was also noted to have left carotid plaque. So they did a left carotid endarterectomy a week later, and then the patient recovered with minimal residual deficit and his hand got better. So I think what this study highlights is that there are so many reasons why patients present with abnormal neurologic deficits post-surgery. This one it seemed very consistent with a peripheral neuropathy, but was actually a stroke. And even other alterations in consciousness that it's very difficult to actually define. We don't want to do a CT on every patient that comes out with any kind of abnormality, but any focal deficit certainly should be investigated and considered as a potential stroke. The other thing is, when do these strokes happen? So the reason a lot of us don't see them in our practice is because they happen, only about 15% are quoted to happen on the very first day, like when patients first come out of the OR. Most of them, like MIs, happen in the first couple of days, so often when they're up on the ward and we're not necessarily involved. In terms of screening for patients with perioperative stroke, this was another really good study that just described what's happening to them after stroke. And 10% were noted on emergence from anesthesia, so they woke up abnormally or didn't wake up. 15% had only altered LOC. So you can imagine how difficult it would be to immediately recognize a stroke when the patient only has altered LOC after surgery. I mean, we all know that's, even when neurology comes to look at them, they ask us, is this normal? Like, should the patient be awake? So it can be very hard to distinguish what's abnormal and what isn't. So, and these authors found delays in neuroimaging and limited intervention when they did get diagnosed with stroke. So what is the ideal stroke screening tool? Like, do we do routine screening? I'd say most places do not. Even though we may do routine troponin monitoring, we don't actually monitor patients for stroke. So we need something that's practical. It can't be elaborate the way the way a neurologist would examine the patient is probably not practical for us to do routinely or having our surgical colleagues. It needs to have good sensitivity. I think we're more concerned about picking up the strokes than if, we may have false positives, but I think being sensitive is very important so you don't miss them. And then reasonable specificity. You don't want to do a CT on everybody, but you also, I'd rather do more CTs on people and not miss a stroke. So this group just looked at a systematic review, looking at what we should do for screening for perioperative stroke. And their conclusion was that we lack validated screening tools, but they did recommend the modified NIH stroke scale, which looks like this. Most of us wouldn't have done this in our routine practice, but it's basically a limited version of the NIH stroke scale, which is quite a lengthy examination. So it looks at all these different things, but it does take, we've done this in some of our research, it takes 3 to 5 minutes, which is, I think in our world is actually quite long. But so this is what it looks like. When we applied it to postoperative patients after non-cardiac surgery, the first thing we noted is that in the first day, you see a lot of changes in this scale, and none of these patients had strokes. So what you see is a lot of noise, especially when they're emerging from anesthesia. And then in this study, the patients, we did a brief cognitive screening. If they had cognitive impairment, it predicted that they would change their score more. So it just shows that if you're trying to find the highest risk patients, you're actually going to see a lot of noise when you start screening them with these tools, especially on the first day. After that, it gets a bit more reasonable. Other guidelines have recommended using large vessel occlusion stroke screening tools. So those are because if we can do an endovascular thrombectomy right away, we want to identify them immediately. And these stroke scales are all screening tools are actually quite simple. These are sort of your typical fast, quick screen. And they were actually developed largely for pre-hospital stratification. So when a paramedic would bring the patient into hospital, they could immediately notify the team they might have a large vessel occlusion stroke and then activate for thrombectomy. But there had been very limited data looking at how we apply those into surgical patients. It was all in community stroke. So we just applied it in a pilot study, looking at potentially doing a larger study later to look at how patients were they able to use this tool and how much noise did we detect similar to our non-cardiac patients. So these were cardiac surgery patients. And what we found was that so these were the missing assessments. So could patients even do it? That was our first question. You can see that there was actually quite a lot of missing assessments. They couldn't complete a whole score on day 0. Not surprising when they're sedated and this was after extubation, but they were sedated. And then on post-op day 1, there were specifically the 2 tools had a higher rate of missingness. So I think the rest of the tools seemed pretty reasonable. And by post-op day 2, there was a low rate of missingness. And we found that it was the upper and lower extremities that people weren't able to do because of pain or they didn't want to. So there is limitations that these wouldn't exist in the community stroke that we have in our surgical patients. So more to come on that. We just don't have a mechanism, but I still think we should be screening patients in some form. So treatment of perioperative stroke, that I've just summarized the Canadian and the US guidelines for treatment of acute ischemic strokes, just so we're all aware if we have a patient who has a stroke, what are the options? So thrombolysis is reserved for patients who are less than 4.5 hours well. And in Canada, there's a contraindication of 14 days after surgery. So that still means there's 16 days of perioperative stroke time that they could have thrombolysis. And a lot of surgeons, I've had a few surgeons tell us that they would allow thrombolysis even immediately after, depending on the surgery and how risky it was. In the US, there is a contraindication for any intracranial or spinal surgery for 3 months, actually. And in the US, there's a warning of less than 14 days, similar to Canada's. Canada's a contraindication. Endovascular thrombectomy, which is, I would say, exploding in indication and application now with extended windows. So traditional indication was less than 6 hours, but I would say that's largely been expanded now to any patients up to 24 hours with salvageable brain on their perfusion imaging. So, and surgery is not a contraindication. So I think this is where we can actually intervene immediately on our patients with perioperative stroke, especially if they're in a center that offers that therapy. But when you look at, this was historic when thrombectomy was probably less offered less often in this era. But in this analysis, they found that they compared inpatients versus patients who presented as an outpatient with stroke. And what they found is that relatively few received treatment, either TPA or EVT. These weren't all surgical patients either, so they actually could have received TPA. And they found that inpatients had longer time delays to imaging, diagnosis, and treatment compared to outpatients. And this is consistent finding that if it's actually better for you to have a stroke on the sidewalk outside the hospital than it is in the hospital, which I think is actually a bit tragic, but it's just people are not thinking of that when someone's in a hospital bed and they present with an abnormal symptom and they don't come to you saying, oh, I think I have a stroke. So it's something to be aware of that any inpatients we generally actually receive less good stroke care than outpatients. And we're just going to go through some outcomes and then finish with covert stroke. So if you we looked at the NISQIT database just to see what the outcomes were after this, because they have fairly robust follow-up up to 30 days. There a high rate of mortality. So a quarter of the patients die after perioperative stroke, which is very high, I think, for a complication, and why patients should probably know about this if they're high risk. Obviously, they have a longer length of stay, but that's not surprising, but a high rate of being discharged to a non-home institution. So quality of life implications and resource consumption. And why is it so bad? Because these rates are quite a bit higher than community stroke as well. And there's likely a synergistic effect between the surgical environment and context of anemia and hypotension and all the other things happening to the patient at the same time as you have ischemia-induced cerebral autoregulation abnormalities and chemoregulation abnormalities. And now you've added in all the other things around surgery. So, and it increases your mortality rate by 8-fold. When we looked at trends over time in the NSQIP database, we had hoped to see some decline in mortality after stroke, especially after the guidelines formally changed in 2015 to recommend EVT, which we would think would be a good option for these patients that maybe were improving outcome. But at least to date, there's not a clear reduction in mortality yet. Hopefully that will come. But again, I think there's more work in terms of clinical practice for us to adjust to screening patients more aggressively and treating them more aggressively. And then the risk factors for having a higher rate of death after a stroke is how close you were to your surgery, which makes sense, whether you're transfused, and other complications that you sustained. And then we're just going to finish with covert perioperative stroke, which is an emerging area of I would say at this point of research interests, but maybe one day it will be in our clinical realm. So a covert stroke is an acute brain infarct that is detected on imaging, typically MRI, because it's very sensitive, in a patient who has no clinical stroke symptoms. So it's somebody who you wouldn't know had a stroke, but to be honest, if you were a neurologist and very detailed, I think sometimes we miss those strokes that are actually not covert, but they're difficult to detect. However, the idea is that they're found on imaging and they don't have clinical symptoms. And the Neurovision trial is looked at non-cardiac surgery prospectively. They enrolled all non-cardiac surgery patients. They were higher risk patients, older, and having more invasive surgery. And then they did diffusion weighted imaging MRI scans on them after, which shows if they had an acute infarct. And that defined the acute period, so they could distinguish between old infarcts and new infarcts. And they found a 7% overall incidence of perioperative covert stroke, which is, I think, quite high when you look at patients who are not. These are not patients who had identified as having a stroke, and they didn't necessarily weren't told about these risks or what does it mean. And 13% had multiple infarcts after their surgery. They also found in both groups similar rate of chronic infarct. So this was not dominated by patients who'd had a previous stroke. This was actually similar and new in patients who both had and hadn't had prior strokes. So what does it mean? So this is not a randomized trial. This was an observational but prospective, well-done trial. They followed them for a year to actually looked at their delirium risk, and they also looked at cognitive dysfunction at a year. And what's very concerning about this analysis is that perioperative covert stroke increase your risk of cognitive dysfunction 2-fold at 1 year. So it's whether that's causative, we don't know, but that is certainly concerning. It implies that there's something that's more meaningful. And not surprising, age was a risk factor for cognitive dysfunction, and having orthopedic versus other types of surgery was protective, which also makes sense. And what's interesting too is that covert stroke was associated and predicted having delirium immediately after surgery. So I think this opens up a whole bunch of questions that I think some delirium that we see after surgery could be related to having subclinical or covert strokes that we have not recognized and we don't image, so we don't know. And also these covert strokes, we still don't understand how important they are. We know they're happening to a lot of patients. So almost 10%. So what should we do about this? That's the issue, is how do we prevent it? And is this a causative relationship, or perhaps it is possible that a year later they've just had more strokes over time and that's contributed to their cognitive dysfunction. But either way, it's a marker for something that with the patient. So in summary, perioperative stroke is uncommon, but less so than we'd think in some of our high-risk populations, and it's a highly under-recognized complication. So patients don't get recognized and they don't get treated the same way as somebody who presents from the community. So it's important to be vigilant, especially when somebody has numerous risk factors for perioperative stroke, especially a prior stroke. The most important risk factors are older age, prior stroke, the roles of hypotension and our end-tidal CO2 management are more murky and unclear, but I still think we should always avoid hypotension anyway because it's good for the patient. I'm just not sure it's specific to perioperative stroke, although it makes sense that we should avoid it. And CO2 management is emerging. I don't think we have as much data, but I think it makes sense that we should probably, again, try to keep them into their normal range. Prevention strategies largely include delaying surgery after having a stroke and not doing surgery right away, possibly up to 9 months, but definitely for 3 months if possible. Obviously, we risk benefit, and if they have cancer, we can't do those things. They generally have very poor outcomes, which is an argument for risk counseling for our patients. Although EVT as a thrombectomy is underutilized currently, I'm hoping that will become more frequent. And being closer to your surgery is a marker of poor outcome, and patients should be monitored closely if it happens certainly within the first week. And covert stroke is just an emerging area, fairly common and a very needed area of future research to understand what that means for most of our patients, given how common it is. And then lastly, these are the two guidelines that are published currently. So one is from SNAC and the other one is from the AHA. And they're both very similar, but I direct you to those because they have very good summaries of the evidence and will help you guide your clinical practice. And with that, I'm happy to take questions. Thanks for your attention.
First, thank you for that presentation. You talked about anesthesiologists should talk to their patients about the risk of stroke.
Yeah.
I sort of, being very dichotomous, think about surgeons should talk about surgical complications, anesthesiologists should talk about anesthesia complications.
Yeah.
You've said that the large majority of strokes don't occur on the day of surgery.
Yeah.
It's unclear that they're any different depending upon what we do with anesthesia. Who should really be talking to the patients about this?
Yeah, great question. Thank you. I think surgeons I should be clear. They should also be talking to their patients. I think I'm looking at what we control, what we can do about it. I think surgeons often do list it in their long list of complications, but I don't necessarily think the patients, especially if they're high risk, I think always it should be a bit individualized. So if you're very low risk, I don't think scaring people too much is actually all that useful. But if someone has, 3 or 4 risk factors and a prior stroke, those are the patients that I make sure understand that they're at higher than average risk, because I think especially if it's elective surgery, or if they want to go ahead earlier than what we might recommend, then I really do have a discussion with them.
I have just a question about anemia treatment, because we know that if you give blood, you increase the risk of stroke, at least in OB literature. So you should treat anemia, but then you increase the risk. And what's the optimal hemoglobin range?
Well, we don't, the first thing is we don't have clear evidence to say what we should do. And like the whole anemia transfusion argument in every complication, it's always both is bad, right? So anemia is bad, transfusion is bad. So what do you do? EPO is bad too, apparently, in traumatic brain injury and some other. So we don't know. I think it's a balance. I think if we can avoid, it's like everything. If you can avoid anemia coming into surgery, all the best. Like that's what you should do. IV iron, do all your preoperative interventions that are not associated with negative outcomes. However, if you're stuck, like the patient's anemic, I would go by what we know generally about the brain and anemia, which even that's a bit vague. And I would say anywhere between 80 to 90, 8 to 9 here, Canada's different, hemoglobin, that seems reasonable, but I wouldn't say there's robust data to say a transfusion threshold, for example. Yeah.
Hi, thank you very much for your talk. You showed that there is no evidence that perioperative hypotension is associated with postoperative stroke. Our residents are taught to keep blood pressure within perioperative level, right? Yeah. Within what is said the morning of surgery, or what is in PACU or in pre-op. And I always struggle between the resident, what they're told to do, and the surgeon's expectation. Above all, I work mostly in orthopedic surgeons, and orthopedic surgeons, they want, 50 of systolic throughout the case. So
Yeah,
now
ideally, yeah.
that is extreme as well. But I wonder, how do you manage blood pressure management during surgery? What do you tell residents to do? And if you can make maybe a comment about the different type of surgery, it's different than having an elective hip replacement compared to having a vasospasm treatment during in a cath lab. And what are your thoughts about neurovascular coupling, for example, during surgery? Because I was taught during residency that the brain under anesthesia doesn't need all this cerebral perfusion that you need while you're giving ground rounds. So now I have a relatively healthy patient who's coming for surgery, and sometimes I see patients bleeding during surgery because the systolic sometimes is kept at 150, 180, as it was in the pre-op. So I always struggle to teach certain concepts and to adapt to the different type of surgery and patients.
Yeah.
Thank you.
Excellent question. Let me synthesize my thoughts. So the first thing is that I think I'm not advocating for hypotension, just to be clear. I think we should avoid it just because it's good for patients in general. As a hypothesis question, it's interesting that we don't detect these associations, but generally speaking, hypotension is not good for patients. As far as what level of blood pressure is appropriate for patients, I tell my residents that there's no motherhood statement about blood pressure anymore. I think that every patient has a different threshold and a different need depending on their comorbidities and their surgery and the risk benefits that go with that. I know that's a very ambiguous thing to say, but I do think that we do less hypotension than certainly when I first trained, where we were pretty lackadaisical. And if the ENT surgeon wanted the blood pressure mean to be 60, we just did it. But I don't do that anymore. So if in fact, I was just asked a few weeks ago, can you lower the MAP to 60 in an old patient with carotid stenosis? And I was like, no, actually, no. That's just not how we're going to control the bleeding now. We're going to do other things like TXA or whatever we need to do. But I don't think hypotension I think it's negative for patients. I think that it's not clear how we might prevent stroke by mitigating hypotension, but it's still a good idea to do so. And I don't think there's any one threshold. I mean, there's one prospective trial, but it wasn't on brain neuro outcomes, but it showed reduced complications when I think it was within 20% of their normal. So I think those are reasonable targets. Yeah.
Hello, thank you. That was a fantastic talk. I'm a cardiac anesthesiologist, and there's a lot of interest in different monitoring
Yes.
modalities, and I'm just curious your thoughts. There's a lot of ambiguity about some of them,
Yeah.
a lot of faith put in them, but in terms of what might be we thinking about going forward as good ways of making sure we have all the monitors for the heart and other things, but
Yes.
not a lot these days for the brain.
Yes, that's also a very good question. And I didn't get into it's actually such a big topic. I don't want to be too superficial. Cardiac surgery, I'm assuming you use a lot of cerebral oximetry, probably. I think at our institution, we use that pretty routinely. The evidence around that, so there's studies showing that you can associate sometimes with outcome. And in carotid endarterectomy is another great example. You can predict deficits if you have a drop in cerebral oximetry. The issue is whether using that monitor changes anything. And I'm not saying it doesn't, but we have not got to that yet in the literature. So I think in cardiac surgery, they're doing trials on this. Like if you use an algorithm to change their oximetry, can you improve their cognitive outcomes after? Maybe not even stroke, but their general function, because maybe they are having covert strokes and we're somehow helping them. So I hope that will come, and that has potential for sure. What's a little disappointing or just hard to interpret, so even in carotid endarterectomy, which has a fairly high stroke rate, and we know we're inducing cerebral perfusion and deficits to them, we can put all these monitors on, and we can put more monitors, the better, to predict outcomes. So you can improve your sensitivity and specificity on predicting their deficit, but we have yet to show anything that changes their outcomes. So we can't show that just because we put a cerebral oximeter on, that we made them better or had a lower risk of stroke. we can put on evoke potential monitoring, we can put on EEG monitoring, all those things. We just detect it better, but we don't necessarily change it. And that's because they don't just have stroke. When we have the monitor on, they have it afterwards, or they have microemboli and we can't really change that. I would say it helps us with blood pressure management and other things. And so that I use cerebral oximetry, I think has a role in these types of surgery, or even in a really fragile patient with cerebral vascular disease. Why not? Like, why not keep their cerebral SAT higher? But we don't know that that actually changes their outcome. So, and again, as you saw, most of the strokes happen after surgery. So even if we put a monitor on in the surgery, it's not, I think it's because they're getting these emboli or thrombosis after surgery. So we're not actually going to impact that as much. But anesthesiologists love monitors and we love numbers. So I'm sure we'll keep using them, but yeah.
You want to address one of those?
I do, but go ahead first.
Great talk. I have a question on the management. So a lot of this is elective surgery, patients coming from the community. What about, the care of the patient with an injured brain, a subarachnoid or a TBI that needs emergent surgery? Is your management to that differently? And if so, how so?
Yes. And that would be so someone with an acutely injured brain, even concussion, there's starting to be some data, but not much yet, that the outcomes are worse. And it's certainly, there's relationships. I think blood pressure management in that case, where there's an acute injury, is likely very important, and we should avoid hypotension. We don't necessarily know exactly, each patient's going to be quite different. But I also think that if we can avoid surgery or delay it somewhat, seems to make sense in those cases as well. But you're limited in when it's emergency surgery. But maybe even, waiting until they're not as anemic or they're more stable, their oxygenation's better. If they're really sick otherwise, taking a secondary insult to the brain is not good in that period. Yeah. We know that having recurrent surgery after a brain injury is, like TBI type injury, is not good. It associates with worse outcome for sure. Yeah.
Two questions from our virtual audience. Role of smoking cessation in periop stroke 1, and 2, is there a way we can monitor, say, CK's BB isoenzyme? Does that help us predict or detect?
Yes, both good questions. So smoking cessation, smoking is a risk factor, but there's no data to show that if you stop smoking, you're going to do better. It seems to make sense, though, that in general, you would do better if you stop smoking. So I would say, go ahead. That seems like a good idea, as long as you have enough time to do so before the surgery. With respect to markers or blood tests for stroke, there's interest. There's lots of investigation around some, trying to look at different neuroinjury biomarkers, but none of that has been implemented or validated in our setting. Yeah. If it was like a troponin, that would be ideal. But it's not as clear, the relationships. I feel like cardiac people are lucky because the troponin is very specific to the heart. Like, you can really pick it up, but neuro isn't as easy to just look at a biomarker and see if somebody has a neurologic injury. So it's more complex. And doing imaging, like ultimately, if you did MRIs on people all the time, yes, you would detect their strokes, but that's impractical, right? We're not going to do an MRI on somebody every day. So it's good if you need to diagnose them with a stroke. The other issue is that patients after surgery, I know just through research, they don't like doing MRIs on them after surgery because they've got a whole bunch of metal in them typically, and then it's like a million hoops to jump through to get someone in an MRI scanner. So it's not practical.
And there's one last question.
Okay.
Someone has a stroke in the hospital, so
Yeah.
the diagnosis and the treatment is delayed.
Yes.
You have a stroke in the community, which is
Yeah.
the opposite for cardiac arrest, right? The
Yes.
outcome is better. I wonder if there are initiatives or discussions that are going on and being taken to avoid this to happen and have a better management of
Yes.
strokes.
Absolutely. And I don't know about your institution. I imagine like we have actually improved things quite a bit. We have a code stroke activation now in our EMR. So basically it's an order set now. You just write stroke, hot stroke, and it actually pages neurology. It activates the radiology stat. You don't have to make a million calls. I mean, we do a very high risk cardiac surgery population. Everybody's on ECMO and VADs. And you'd think we would be able to handle, like, they get strokes. So we should be doing this very quickly. So yes, having protocols and everyone knowing that these are immediate complications that need to be done right away. So that's the other thing. This is everywhere. People don't always recognize this is an absolute emergency. It isn't like, well, maybe we should do a CT in the morning. This is like, you got to do this now if you're going to save brain. You can do a CT in the morning, but they're going to be, that's probably going to be over at that stage. They won't be able to have thrombectomies. And so yes, I think having clinical protocols, having education, having awareness, this is sort of why I like doing these talks, because I think once people hear about this, then they're more aware any focal deficit after surgery should really be investigated right away. It's not easy. I'm not saying it's easy, but in fact, even in the neurovision study, which is in their pilot study, I think, they were just doing MRIs on people, right? So there was no, and they weren't doing clinical assessments. What happened is they actually had a patient go to MRI who had a big stroke, not just a covert tiny blip. And they went back and were like, wait a minute, the radiologist is like, this patient having a stroke. And they went and the patient had full deficits on the ward, but no one had noticed. But they got to the MRI. So it's just, that's the kind of, I mean, this was across Canada and the US, I think. So that's the reality of people aren't really examining them in that way, the way they might in the emergency room or, yeah. So it's definitely a problem, and that's pretty universal, I think, across our centers. Yeah. Okay.
I think we are at the end.
Okay, great.
Thank you very much.